Good afternoon and welcome to the final session of the cardiology track as well too. This is session 8 after 5 days of exhausting lectures, and I would like to thank every one of you for coming to this afternoon for the last of the tracks as well too. My name is Nathan Better, and my co-chair today is my friend of mine, Samir Duray from Pakistan, and we both welcome you to this very interesting session. The numbers have been down today, but I have actually deliberately left probably hopefully the best to last as well. This is the session which is going to answer all questions. And just while people are drifting in, I just wanted to, as the chair of the track's privilege, I just want to, just for 2 seconds, just to thank a few people for what I think has been actually a very exciting cardiology track as well too. A lot of the people come up to me and said congratulations for getting this track organised, but in truth I could not have done this without the help of my friends in the committee as well too. All the people that have come actually out here, our international speakers, we've got 3 of them here this afternoon, have really made this conference, and I'm very much indebted to Shamila, to Prem, to João, and the other international speakers for coming to this meeting. The organising committee has included João as the co-chair of the program, and my friend Barry Ellison as well also. And one person, I think he's had to go back to Adelaide, who I want to specifically mention is Steve Unger. He's a person, works at the Queen Elizabeth. He's done this all without fanfare. And if any of you are from Adelaide, please making sure that I actually have addressed him publicly, because everything I've asked for him to come in the last minute to help with grading of the abstracts, to chairing the conference, to find extra speakers, he stepped up, and without him, this would have been a really tough chore. But as a thank you to all for being involved with this program, I really am indebted. Coming back to the topic for this afternoon, we're going to finish with this session 8 with Controversy Corner. We're going to have this as 2 fun debates to finish off with, and I've got some key speakers. We're going to divide this program into 2 halves. And the first half is going to be this controversy regarding anatomy. Do we go with function or do we go with anatomy to sort our patients out? And the second half of the talk, which is something which is a real burning question, is do we all have to go out there and get cardiac PET, or is cardiac SPECT good enough? And we haven't got any better speakers to help sort this out. Because it's a debate, we have very strict debate rules. Each speaker will be limited strictly to 15 minutes. There'll be it's strictly Queensberry rules, so gloves must remain on at all times. At the end of the 15 minutes, there will be 5 minutes for rebuttal. People will have the option of having any slanderous slides if they wish in that 5 minutes, or just to talk. And then there'll be 5 minutes of questions from the audience. And at the end of each of these debates, we will have a vote to decide who wins, or who gets paid the most as well too. And I have the casting vote. You can borrow Barry's. So the first of our debates is on Controversy Corner is who's on first, anatomy or function? And defending the anatomy wins, my good friend Barry Ellison has come to us from Wollongong to answer that question for us.
Thanks, Nathan. Just again, a thank you to the organisers of the 12th Congress of the World Federation of Nuclear Medicine and Biology for asking me to talk, and particularly to Nathan, who we'll all agree, he's put together an amazing cardiology track, and honestly, he deserves applause for that more than anything else. It's not often that you get so much good cardiology in general nuclear medicine when there's the thing called PET that everybody likes to talk about, but we'll talk about it another time. The other thing is these debates are always very difficult. I'm debating a person who's vastly experienced. He knows more than most of us about nuclear cardiology, but he's a really nice guy, and he actually said to me, he agrees that CT is a better test. So he said he'll go soft on me, all right? So I'll just sort of run through some of the literature, so thanks anyway, Jean. Thanks, Jean. That's very nice of you, honestly. Now I've got to try and work this thing. That's interesting. There we go. All right, sadly, no disclosures. All right, so who or what are we investigating? Are these stable patients with chest pain, or are they ischemic type symptoms, with ischemic type symptoms? Unstable patients, probably not. Asymptomatic patients, again, probably not, but certainly preoperative evaluation. We had a nice argument yesterday about that. Of course, that has to be included. And then what are we looking at? Are we looking at accuracy? What outcomes? What are the outcomes? Is it death, MACE, unstable angina, or revascularization? So what is required for an ideal non-invasive test? It's got to be accurate, sensitive, specific, high positive predictive value, high negative predictive value, and of course good outcome data. You need excellent anatomic detail. You want early diagnosis, coronary artery disease and not ischemia. And you want excellent outcome data. And of course, you want functional data. Now, there've been many meta-analyses of all these studies, and you'll see I've put one up here, I've got others. It's interesting, in this particular group, which are very well-known publications, SPECT specificity is low. They're not all like that, but the general feeling is around 85 and 85 for SPECT, and of course CT in the 100 and 89%, and that's quite common about CT, whether it's per patient or per artery. And I think that's well established. And even before Confirm Registry, there were some good long-term prospective studies. And if you look at significant stenosis on CT, 12% per year event rates, and excluding revascularization, about 6%. And non-significant stenosis, about 1%. So even in the early stages of CT, and of course there's some hazard ratios down there, I can't go through them all, but very good data for events. And this is Matt Budoff's study on per patient analysis and per vessel analysis on the accuracy of CT versus invasive coronary angiography. And there again, you're seeing very high sensitivity specificities and particularly negative predictive values for both vessel and per patient at different thresholds of 50% or 70% stenosis. So their conclusion was a high diagnostic accuracy for detection of obstructive disease at thresholds of 15-70%, and a 99% negative predictive value at the patient and vessel level. So CTCA at that time was an effective, non-invasive alternative to RCA to rule out obstructive disease. That was a very important paper, and that had great significance. Now, can we really separate these two? When you look at Romicat, Akron, Core 64, all studies done in the emergency situation, and at the end of the day, they all had similar outcomes at short times, at around about 28 days. There was no significant event rates in the early phase of these studies, of these patients that were studied in the emergency room. And clearly these shows that CT to be at least equal or possibly better than functional imaging, and particularly with respect to time to diagnosis and the length of stay in the ED. So same outcomes, get them out of the ED quicker. So that's early acute, in the acute phase. Certainly not worse than MIBI or MPS. Now, diagnostic testing today, and we've all seen the slide, everybody's seen the slide, but the problem is diagnostic testing identifies end-stage disease, and that's really a problem with functional imaging. So in the majority of cases, the first sign of coronary artery disease is an ACS, or an acute coronary syndrome. And is it really reasonable in today's times to perform functional imaging to diagnose late-stage disease, given that quite often the first symptom of coronary artery disease is an acute coronary syndrome? So, PROMIS and Scott Hart. Now, there have been some comments about PROMIS and Scott Hart being old news. They are not old news. These are two most significant studies done comparing head-to-head standard of care or MIBI versus CTCA. They are extremely important studies with very good outcome data. And this is the PROMIS study from Pam Douglas's group, published in the New England Journal. And very simply, they took 10,000 patients, about 5,000 randomized to standard of care, and the other 5,000 to the CT arm. And effectively, the outcome data at nearly 4 years was much the same. And the outcome data really at non-fatal myocardial infarction, death, were the primary endpoints. There were some composite endpoints as well. Very similar. Again, CT was not inferior. The funny thing about PROMIS, and I believe that PROMIS was powered to make CT look better, it didn't. But it was still a very good test. Scott Hart was an outstanding trial from the UK. Basically, Michelle Williams and David Newby did this test. Similar type of thing, but they have a different health system. So they're basically patients that had chest pains and thought to be anginal were sent to their cardiac clinics, and they were randomized in a similar way. About 9 to 10,000 patients, and again to a standard of care arm and a CT arm. And again, the outcome data, if you look at it, not a lot of difference between the two. The problem, I believe, with Scott Hart, it only went for 1.7 years, and I think that there wasn't enough time to really see a separation. And personally, I think that if they'd gone longer, CT might have performed. And And with the CTCA group, it was associated with a 38% reduction in CAD, death and non-fatal infarction. However, this was just short of statistical significance. So they got close, but probably not long enough. But and to quote many people, not Leslie Shaw, the diagnostic certainty of the CT arm was what really made this study very good. There was diagnostic certainty, not obstruction, but diagnostic certainty. There was a reduced need for further stress testing or increased use of invasive coronary angiography and changed treatment regimes that might be associated with fatal and non-fatal myocardial infarction. And the diagnostic information occurred in 99% of patients in spite of obesity, high calcium score, and atrial fibrillation. And that was really significant. The standard of care group had unrestricted use of further stress imaging is needed to explore the effect of additional CTCA, opposed to doing a head-to-head. And the results focused on the effect of CTCA on the patient-centered and clinical-centered outcomes rather than comparing diagnostic accuracy. That's an important difference with Scott Hart and PROMISE. Now, with CT vulnerable plaque, you've all seen these slides. Vulnerable plaque is a significant finding. And fortunately, I'm an imaging specialist. I'm not a cardiologist. Somebody is going to get up and say, what you're going to do about it. I don't know what you're going to do about it, but if it was my MIBI or my CT, I don't want to see vulnerable plaque. So I'm going to leave it to the cardiologists to tell us what they have to do about it. But the point is we see it. Why is it important? Maruyama's group have shown that if you've got some of the characteristics of vulnerable plaque, you only need two: a low attenuation plaque, positive remodeling, spotty calcification. Your event rate is substantially higher, 22.2% higher if you've got two of those features. Vulnerable plaque cannot be good for you. I don't want a normal MIBI and vulnerable plaque. It's not a nice finding. And that's where CT is very important, giving that type of information. So CT identifies critical atherosclerotic features of future events, while stress imaging simply identifies the end-stage disease. Okay, initially the debate was all about anatomy and function. Now is there a real difference? I'm not going to talk about CT perfusion. It's too complicated. It's, at the moment, the current literature, they're all site-based, but it is two tests. And I think CT perfusion, I don't see a future for it. But FFR-CT, it's the same data set. You don't do anything different. You just add a computer program to it. Now, why is FFR-CT so important? If you look at the FAME study, which really, in simple terms, FAME was an invasive FFR study against with angioplasty and angioplasty alone, and the FFR-directed study clearly had better outcomes than non-FFR. So clearly, I think it's well accepted now that FFR, invasive FFR, is still probably the gold standard in this. I know there are difficulties with all of them, but it is probably the gold standard in revascularization of a single vessel. If you take this study now, which was very recently published in JACC by really Udo Hoffman's group and Michael Lewis, the chief author, looking at non-invasive FFR or CT FFR derived from CT. Now, they took a group of patients from the PROMISE arm, the CTCA, the CT arm of PROMISE, about 550 patients who were referred to RCA within 90 days. They had 90 days after the CTA. Not all of them were eligible. At the end, they did 181 FFR CTs from this group. And this is one of the few pictures I'll be showing, but you can see, how does this work now? You can see the CT showing this marginal branch obstruction. The FFR is significantly reduced, and of course you can see it in the invasive angiogram, and of course no doubt you'll see the FFR improving after revascularization. And that's the sort of study they were doing. So in this hypothesis-generating study of patients with stable chest pain referred to RCA after CTA, they found that FFR-CT may improve the efficiency of referral to RCA, addressing a major concern of an anatomic CTA strategy. FFR-CT had incremental value over anatomic CTA in predicting revascularization or major adverse events. So another very strong thing in favor of FFR. Now, if you take Michelle Williams from the Scott Hart group, they also took some of their data and went further with this. longer outcome studies. And I think this is a very nice and very clever study. And all they did was they took the CT arm and the non-CT arm, and they implemented therapy. Now, the study's a little complicated, but they do. This thing's not working, but they started at about 50 days after randomization. And what you see in this group is a significant change in the coronary event rate in those patients when the CTCA arm therapy was started, as opposed to the non-CTCA or standard of care arm where therapy was started as well. And I think this is a critical study and very helpful to the Scott Hart group, and very helpful, I think, to all of us. So if you look at this, the standard care alone versus CTCA standard care, the two graphs are basically similar, but they just separated them from when they started treatment and from 0 time. It didn't change much early, but certainly now this is a much longer follow-up. It's over 3 years now, and I think you're seeing a very strong separation in the outcome in terms of major adverse events. All right, so what Michelle Williams' group have really said is that they demonstrated that CTA facilitates the more appropriate and effective selection of invasive coronary angiography for patients with suspected angina. It changed downstream prescription of preventative therapies and the application of coronary vascularization procedures that were associated with an apparent halving in the rate of fatal and non-fatal MI. And the most important thing about this study, I believe, it's the first time that a non-invasive diagnostic test for coronary artery disease has demonstrated benefit in hard clinical outcomes through better target investigations and treatments in patients presenting with suspected angina pectoris due to coronary artery disease. So benefit, therapeutic decisions were made on this basis with good outcomes. Now, the platform study is also a very good study, again using CT-FFR. This is again Pam Douglas's group, and this was published a few years ago. And really what Platform did was that they took randomized patients, again, planned non-invasive testing, and those were planned with invasive coronary angiography. This was real-life clinical stuff. It wasn't, there was nothing before, and all they did was take the people with standard non-invasive testing, and they did CTA with FFR in them, and the same with the group with a planned invasive coronary angiography who weren't having non-invasive tests, and they added an FFR, a CTA FFR to that group. And again, their primary endpoints were much the same. But the critical thing about this test was that in the column on the right, the FFR CT in the invasive group, it reduced by half the number of patients that required invasive coronary angiography. So they were booked for invasive coronary angiography, significant reduction in the number of angiograms performed based on CT-FFR. So really, the crux really is that it reduced the amount of ICA from 73% to 12% by simply adding a non-invasive CT-FFR into that study. So really, what have I got? I've got accurate, sensitive, specific, high positive predictive value and negative predictive value, good outcomes, excellent anatomical detail, early diagnosis, and excellent outcome data. And I think with FFR-CT, we're really on the way to having good functional data that matches anything that MIBI can do. And I'll leave that to my opponent now. Thank you.
João Vitola from Brazil, and he's going to talk about function.
Good afternoon, everyone, and thank you all for coming to this session, the last session. And I want to take this opportunity to thank the organizing committee for bringing me to Australia, and Nathan, especially you, for organizing. This was really a great meeting. Thank you. I think Barry and I will agree that both of these are excellent tests when applied to the right patient. And the clinical situations will be different for each given test. The strengths of CT, it can provide us early diagnosis of disease, even in asymptomatic patients when we do calcium score. It can tell us about non-obstructive coronary disease and can allow us to start secondary prevention. It also has a very high negative predictive value, and it excludes disease with very high accuracy, avoiding us from undergoing other unnecessary tests. When we look at the strengths of nuclear, we know it can quantify and localize ischemia. We know it can estimate risk. You know it can guide management, and especially it can allow us to monitor our therapy, which more and more patients being treated with medical therapy, we need a good test to know that our therapy is being effective. It can help us to prevent unnecessary revascularizations when the study is normal. And it can be applied to most patient subgroups: renal failure patients, bypass patients, patients with left bundle branch block, patients that cannot exercise, etc. Exercise and being able to do ischemia test with exercise is one of the advantages that we have in nuclear cardiology that we should not forget, because most of our competing modalities do pharmacologic stress, and there's so much more information we can obtain when we combine imaging with all the exercise data we can obtain on the treadmill or bicycle. Many patients with advanced atherosclerosis detected by CCTA, such as this patient, in fact have no ischemia. And the real question is, how can we prevent unnecessary revascularization so frequently performed, such as was shown in the PROMISE study that my friend Barry just mentioned, this very important randomized study of about 10,000 patients. Interestingly, no difference between functional test and anatomic test, but one major difference: many more revascularization if you started with an anatomic test. So more revascularization, but no real benefit in terms of decreasing event rate. So look at this patient here. This is one of the patients that I follow in our lab. 70-year-old diabetic patient with atypical symptoms that has these findings, these anatomical findings, with a calcium score above 6,000. This is the highest calcium score I ever seen. We performed a MIBI study, which was normal, and we followed this patient. This patient exercises 10 minutes on the treadmill. Incredible for this amount of atherosclerosis. Normal perfusion in 2016 is still normal in 2018, and this patient is being kept in medical therapy, which is the appropriate therapy for this patient. If this was a patient on the PROMISE trial, I bet you he probably would get revascularized. Interesting to see how a PROMISE-like study would be if you would do this in a developing country. And this was a study run from the IEA, only 300 patients, but it was a randomized study with patients from 6 different developing nations, very high degree of patients with diabetes. So patients were all intermediate risk for cardiovascular events. They were randomized to either nuclear or CCTA. The primary outcome was if additional testing within 6 months was necessary. And CCTA drove to approximately 2 times more additional testing if this was the first test being done. Additional testing meaning many times invasive coronary angiography or nuclear imaging. And I think where Barry and I really agree that both of these tests can be great tests if applied to the right patient. If my patient has a lower probability of coronary disease and I really need a test to exclude disease, I would go for a CT. If my patient is a higher probability patient with more advanced age, more risk factors, etc., an MPI would be really the test to do. The question is, when we are right in the middle, what's the best test to be done right in the middle? Look at this patient, for example. 65-year-old woman, has known disease, had an acute MI at age 63. She was brought to our lab because she was having fatigue on exertion. So we did a pharmacologic stress test on her. As you can see, this patient has already some evidence of an anterior MI in the past. During dipyridamole infusion, this is what happened to this patient. She has very significant ST depression, downslope in ST depression, and this is the image. Well, this image is being processed, and the physician is reporting and calling the referring physician, because these are very significant findings. And why was the physician being so carefully about this patient? Because we know such an extensive defect carries a very high risk of hard events, including death. And when you look at the function, post-dipyridamole function of this patient with a significant drop in ejection fraction, that's another additional data that estimates that this patient has a very high risk. What happened to this patient? 10:36 in the morning, end of image. 10:38, the physician is processing and reporting the study. At 10:40, the patient had cardiac arrest in the waiting room while having coffee. So underwent CPR. After 30 minutes of intense, very intense work, 7 physicians, 4 nurses working, the patient is back to sinus rhythm. She's transferred to the cath lab. The left main is occluded. So, of course, a patient like this with known disease benefits from physiological assessment, and we can clearly estimate risk on this kind of patients. And this is data from our lab, but others have shown similar data that more severe defects, this is specifically in women, over 2,000 women, is highly predictive of mortality. We have come a long way in terms of nuclear cardiology development, and after 45 years with solid literature, we can say that this is a tremendously useful technique if you apply it to the right population. It quantifies ischemia. There are several different ways to quantify ischemia. There's data to support that higher the ischemic burden, higher will be the event rate, and give us a chance to identify patients such as this, a 57-year-old female presenting with atypical symptoms. What is the risk of this patient? We clearly know the risk of this patient based on the current nuclear cardiology literature. How often do we see patients like this in our own laboratory in Brazil? For women, we see approximately in 5% of our patients. In men, in about 11%. And also, we're mapping what kind of characteristics are more frequently related to these very severe defects, such as having a high Duke-Treadmill score, having typical pain, having known disease, having diabetes, requiring a pharmacologic stress. But interestingly, men always have more severe defects compared to women referred to our laboratory in Brazil. So what do we do today with patients such as this, with LAD ischemia of this extent, which we classify as a high-risk ischemia? With the evidence that we have today, we revascularize the patient. This patient we've been following for the past nearly 15 years, and the patient remains with normal perfusion, alive, well, without any cardiac event. Thank you very much.
Thank you, João. And just I noticed from your presentations today, that's the third patient that's arrested in your laboratory today. So seems to be a risk factor, I'm afraid. Might give Barry the right of rebuttal.
Thank you. It's a different item. All right, well, thanks, Joel. I just some issues in the, not so much in the rebuttal, but we are facing a tide and a sort of a tsunami of recommendations. NICE in 2016 revised theirs, and just look at that the bottom part, clinical assessment, typical or atypical angina. They're now recommending CT angiography, and you know that's a considered group of people. This is what we're sort of up against in a way. So what is really the problem? What is the controversy? And are the studies linked? And I think that's really where this is going. Quite frankly, I'm finding it more and more difficult to separate the two. Promise and Scott Hart, same sort of outcomes. Now, I got this slide from Jonathan Leipzig, and it's absolutely fascinating. This was published by Roberto Curie. Of the 385,000 patients in the United States that were sent for invasive angiography, if you look at that breakdown, SPECT, stress echo, exercise stress test, or MR, you've got far less likelihood of finding obstructive disease if you have a test. It just does not make. These are people that have already been sent to the lab. Not that they've been triaged not to go to the lab. When they're in the lab, you're more likely to have obstructive disease if you've had no test. It's just bizarre. But look at the numbers. Duke University Medical Center, not that different, 15,000 patients. If you look at those that went to ICA with obstructive coronary artery disease prior stress testing, again, the positive results were the lowest in those that the obstructive disease were lowest in those that had stress tests, and the same with revascularization. It does not make sense that we're doing tests that aren't really triaging people enough. These are huge numbers. So CTA as an anatomical test, it correlates much better with invasive anatomical assessment. That's the problem we're facing. If you look at these diagnostic performances, I showed you there's another lot of them, all showing very high sensitivity and specificity against invasive angiography. So very difficult to argue about that. So will one replace the other? And that's really where João and I do agree. It's not that difficult. I've mentioned FFRCT. Where's this up to? Just to show you some trials. There's a de facto NXT, the Discover Flow trials. What it shows is that the NXT FFRCT is still the best in terms against invasive FFR in terms of all aspects, specificity, accuracy, and so on. Stress echo, MIBI, it doesn't rate as well. And if you look at the specificity and sensitivity of FFRCT against invasive coronary angiography, and see, you know, it's again very, very high. It's just a very, very, very accurate study. So FFRCT correctly reclassified 68% of CT false positives to true negatives. That's not a terrible thing. It's the same test, just adding some software. It does the job extremely well. No extra radiation. And I'd just like to stop on this cost with FFRCT. It was brought up yesterday or the day before. FFRCT was done by a third party. It was, for what it's worth, the company is called HeartFlow. It's fantastic computational dynamics. They give us a story about how difficult it is. It's not that fancy a computer. It's no longer a supercomputer needed. But the truth is they're now licensing the major providers of our equipment to use the system. Before, you had to take the data, send it to them. They send it back to you with the answer within 24 hours. All the companies have tried to develop their own, but this computational dynamics has been patented by them at every step of the way. So that the major manufacturers can't do it, so they'll license all the manufacturers to do it, and it's not going to be as expensive as $1,000. Even the company that owns it, extremely successful, wouldn't be mad enough to charge $1,000 for a test. It won't be expensive. It'll be like us buying a quantitative package like Cedars. You buy it, you license it, and you'll be able to use it. The cost has to come down. So FFR has been shown to be an accurate tool for identifying exclusion from lesion-specific ischemia. It's good correlation with measured FFR that's invasive, high diagnostic performance and other non-invasive tests, and its ability to guide clinic decision-making is fodder for ongoing investigation. Look at our own data in
30 seconds, Barry.
Sorry?
30 seconds.
Okay. Our own data in Australia, I just want to show you this, that although we are not growing, MIBI, 2.5% of all MIBIs in this country end up with revascularization, about 11 to 12% of angios, and stress echo, 1.5%. So all the tests we're doing, if you just look at this graph, we've grown from 39 diagnostic studies per one therapeutic intervention to 56. We haven't done well at all. So I think really what's happening is that just like nuclear was smashed by stress echo in the last 2.5 decades, where our numbers dropped, I have a feeling CT is going to do the same thing to all of us, to stress echo, to nuclear and echo, where they will take the numbers. And I think that graph that Zhao showed where the intermediate group, I think that will shrink, and that's where nuclear will be, and CT will be on the left of that. And I think that's about all I've got time for, Nathan. Thank you.
Thank you very much. We're going on to the third speaker, Professor Sharmila Durbala. Oh, sorry, your chance, yeah.
So I think what we will have to do in the future is to integrate these different modalities. We have so many great options today to investigate our patients. We're at a very privileged time of so much technology. The question is how to use all of this in a cost-effective way, in a rational way. We already discussed regarding the pretest probability of disease and which test we should apply here and there. And the question really is what we do with the patient in the middle, with the 50%. There's no problem to start with the CT. If we can control the cardiologists, if we can control unnecessary revascularizations, because identifying disease at an early stage is a good thing. We can start secondary prevention. The problem is the stenotic reflex, the dilatory reflex that once you see a lesion, you have to dilate. And that's the real problem. Starting with nuclear and having no ischemia will imply a low risk to that patient, but you may miss a patient that has no obstructive disease, which is a marker of increased mortality too. So perhaps a combination of MPI and a calcium score in the future will be one of the ways to investigate our patients and to integrate different modalities. More and more we're doing cases like this. Patients with intermediate Framingham score, asymptomatic patients many times, high calcium score, go on to nuclear. Non-invasive procedures, nuclear, and then quantify ischemia. And depending on the quantity of ischemia we identify, then we make the decision to send the patient to the cath lab. Right now we're doing a project called the Curitiba Heart Project. Curitiba is the name of the city where I work. It's a unique experience in the world at a city level where we're evaluating asymptomatic men between age 40 to 69 and women 50 to 69, stratifying according to Framingham risk score, the population, re-stratifying risk using imaging, calcium score, and re-stratifying risk again once we find a calcium score above 400, with a focus on promotion of health and secondary prevention as needed, and not focus on unnecessary revascularization. And look at this patient, a 46-year-old man, asymptomatic, low Duke treadmill score, low risk, but a calcium score of 400 and an LAD ischemia. We should, in fact, promote secondary prevention, aggressive secondary prevention in this young man, because we know he has markers of increased mortality. And more we're seeing that even exercise treadmill alone with a combination with calcium score, can identify a subgroup of patients that, very importantly, are at an increased risk and would deserve an aggressive secondary prevention. So what we should be thinking of to conclude is a stepwise approach for the workup of coronary disease. Nothing replaces good clinical judgment. We should start with some basic tests. We consider a calcium score nowadays a basic test. And as a second step, make a decision if we should go for a CTA, if we should go for a nuclear, if we should go for another test. But keeping in mind that once detected, disease is detected, the patient should already be started on medications, because this really has been shown to decrease event rates. Thank you very much for your attention.
Thank you very much. I might just ask you to start there, João, and get Barry to the podium as well. You just start there for us, please. If there's some one or two questions. While everybody's getting their act together, because we will be voting in a minute's time. I haven't decided who I'm going to vote for yet, which of you two guys is the most attractive to vote for. But I want to ask a question to both of you. And I only got this question, which I think should sort the men out from the boys. When you did your presentation, Barry, you said you don't want to have that vulnerable plaque. You don't care whether the MIBI, even if the MIBI is completely normal, you just don't want to have the vulnerable plaque. My question to you both is, what would you prefer to have yourselves? Would you prefer to have a very abnormal MIBI with no vulnerable plaque, or a normal MIBI with vulnerable plaque? Tough question, huh?
A very abnormal?
Oh, no, I'd rather have a very abnormal one, because I know you're going to fix me. If you don't know that I've got the very vulnerable, if you don't know I've got the vulnerable plaque, I've got a problem.
So you're voting to have the abnormal MIBI? That's what.
Because you're going to fix me.
So you prefer, so you think the functional test is best?
No.
Dr. Vitola.
Can you repeat the question?
I want to know whether you would prefer to have a normal MIBI.
Normal MIBI, yes.
With vulnerable plaque.
And have a vulnerable plaque, yes.
Or have a very abnormal MIBI with no vulnerable plaque.
Okay. Then we go back one step. Who's the patient? Am I really the patient?
Yeah.
Or it is the patient with a strong family history of premature deaths? Is that the patient with symptoms or no symptoms? What is the clinical scenario we're working on to make that decision? Okay? If I'm the guy who has a family history of a father having an MI at age 45, I would like to have the anatomic test and to know that I have the vulnerable plaque instead of the normal MIBI. If my family history is people with longevity that died at age 90, and my LDL cholesterol is 130, my blood pressure is 120/80, and I'm having some atypical symptoms, perhaps whatever test I do, nuclear or a CT will be good.
So the functional guy is voting for CT, and the CT's guy's voting for functional.
And therein is the problem. You can't separate them.
Is there any more birdie questions at all?
I have a comment. I think a lot depends on who owns, what the cardiologist owns. If the cardiologist owns angiogram, then because I had a MPS and then I had a CTA and then I had an invasive angiogram, just because my cardiologist kept saying, no, I think we need to go for an angio. So it all boils down to how well you have managed to convince the treating cardiologist.
Thank you. Thank you, Sabi. We'll have a quick show of hands. Who votes for Barry? Who votes for João?
No one.
Who votes for everybody? Looks like it's a draw. Thank you, gentlemen. Okay, that's the easy one out of the way. Now the last talks for the afternoon. Controversy Corner Part 2. What wins, PET or SPECT? And before Shamila starts a talk, I just want to vote from the audience as well too. We're all obviously doing SPECT. Who's doing cardiac PET, not counting sarcoid, but for perfusion PET? Who's doing PET as a matter of course? You've got a lot of work here to do, Shamila.
Absolutely. I hope that by the time you have the next meeting, we'll see a lot more hands.
Me too.
All right. So, yes. So thank you very much, Nathan, for inviting me to this really exciting and great meeting. I'm happy to be here and in the beautiful city of Melbourne. So what I want to do over the next 15 minutes is talk to you a little bit about PET. This is not really a theoretical discussion. It's a discussion on where the field is going and where you want to be. So why cardiac PET? I think all of you know this. Radio tracers are superior, better extraction, image quality is better, lower radiation dose, better detection of multivessel disease, and with hybrid imaging, most scanners have PET CT, so you can look at calcium score and CT angiography. And of course, a lot more clinical applications beyond perfusion, viability, inflammation, infection, amyloidosis, and molecular imaging. And of course, there's an extensive evidence base. So what about higher diagnostic accuracy? So I just want to talk a little bit about how radio tracers affect image contrast and image quality. So here's tracer uptake plotted against myocardial blood flow here. Of course, the ideal tracer is linearly taken up in relation to blood flow. You can see most SPECT tracers, technetium tracers, have this roll-off phenomena at high flow rates, whereas N13 ammonia is up here. So let's imagine a patient who has an inferior wall perfusion defect. So what would you expect? The blood flow in the inferior wall is reduced, so you have that much of technetium uptake. In the non-disease territory, there's maximal hyperemic response to exercise or vasodilator, and you see that uptake, and that's the contrast. That's the contrast you would see on the picture. Now consider the same person, the same disease being scanned with N13 ammonia. This is the same patient from our lab who got a SPECT followed by N13 PET, and that's the defect that you would see on an N13 PET. Why is that? That's because the extraction characteristics are better. Therefore, with maximal hyperemia, you see more uptake of ammonia there, and you see less uptake in the diseased area, and you see much better image contrast. So I think part of the advantage of PET is not just the technology, attenuation correction, but it's actually better radio tracers. We all know that SPECT perfusion imaging is limited to detect high-risk obstructive disease. These are data put together by Dan Berman, showing that if you add all of these features, ischemia, low EF, multiple defects, lung uptake, abnormal wall motion, TID, you increase the ability to detect multivessel disease up to about 83, but you're still losing about 20% of high-risk diseases not picked up by SPECT imaging. Here's an example from our lab, conventional SPECT. We have recently switched over to a stress-first protocol. So everyone starts with a stress-first unless the patient has a history of a myocardial infarction. So this was a stress-first protocol, and we said, should we go ahead with the rest perfusion study on this patient, or should we do a SPECT? So this becomes a question for institutions where you have both options available. So when I looked at this, I said, you know what, this is a female patient. This anterior wall could be attenuation, could be real. I would much rather do a PET scan on this patient rather than give her more radiation and complete a stress. So here's your PET scan. Take a look at the anterior wall now. Completely normal, right? There's no attenuation artifact. However, if you look closely, there's an infralateral perfusion defect that looks completely reversible. You can see it on the short axis there. You can look at the ratio from the septum to the lateral improving, and look at the anterior to the inferior on the lateral side improving as well. So this is the advantage of PET imaging. Image quality is better, attenuation is removed, and you have better detection of disease. More interestingly, when we looked at the flow reserve on this patient, unfortunately it's not showing up very well, globally reduced coronary flow with a flow reserve of 1.6 and each vascular territory 1.9, 1.6, 1.3, suggesting that not only this patient has ischemia in the circumflex, which was potentially missed by the SPECT, but this patient probably has significant multivessel disease plus minus microvascular disease. So this is a sort of additional information. So a lot of literature supporting this, meta-analysis showing that the area under the curve is better for PET compared to SPECT from a different institution showing the same again. What about comparing to other modalities? Here's the accuracy for SPECT in green, PET in red, clearly superior. Here's another study looking at fractional flow reserve as a reference value. Again, you can see sensitivity is better, specificity is better, overall accuracy in purple for PET is much better. Then this was data shown earlier this morning, eVinci study, again very similar. Area under the curve for SPECT 0.7, for PET 0.85. So multiple studies support what we are seeing clinically, that the diagnostic accuracy is better. Now, what about the same patient getting a PET and a SPECT? So here's data from the Pacific study where they used O15 water for PET and SPECT. Same patient getting PET and SPECT. You can see that PET overall accuracy is 85 compared to 77 with SPECT. So all in all, it's not just what you're seeing on images, but there's literature backing the point that accuracy seems to be better. What about lower radiation dose? We know that because PET tracers have shorter half-life, they have little less radiation dose. So here's N13 ammonia, 2.5 millisieverts, rubidium 3.9, technetium is about 9, and thallium is 25. And these numbers are for complete rest and stress. Of course, if you do stress, only stress first, as we have switched recently, this would be half of that, approximately more. How are we using this? This is a young individual with cardiomyopathy, underwent a stress echo, which was indeterminate, and got N13 ammonia stress first image with exercise. 1.2 millisieverts, beautiful quality images, and clearly she has a cardiomyopathy with low ejection fraction, and based on the CFR, invasive angiography was not performed. What about another case here? 17-year-old who was transplanted at age of 8 weeks as an infant. Known transplant vasculopathy, and then the Children's Hospital transplant physician called me and said, I don't want to know CFR on this patient because I know the patient has transplant vasculopathy. What I would like to know is that causing ischemia overtly that needs to be fixed in some way? So here's the stress first N13 ammonia. We took a look at it, said we're not very happy with this infralateral area, so we went ahead and completed the rest. And you can see that infralateral, that whole area is actually ischemic, filling in 2 millisieverts. So again, using the advantage of low radiotracer dose. How about excluding balanced flow reduction? Here's data from our lab as well as from Ottawa Heart Institute showing that if your myocardial flow reserve or coronary flow reserve is decreased, the probability of 3-vessel disease increases. However, if you look at a flow reserve of 1, you still have a big proportion of patients who do not have multi-vessel disease. It's just severe balanced ischemia. And on the other hand, if you have preserved flow, it has an excellent negative predictive value to exclude balanced ischemia. So if you have a normal scan and your coronary flow reserve is about 2, then you say this patient has a very low likelihood of balanced ischemia, almost excluding the need for coronary angiography. The other area where PET has a value, a significant advantage compared to SPECT, is management of advanced heart failure. Of course, here's a patient, 86-year-old with days, weeks of shortness of breath and chest pressure, multiple risk factors. You can see very low ejection fraction. This is N13 ammonia PET-gated study. Resting scan. So we went ahead and performed an FTG viability. You can see substantial viability in the anterior wall, apex, inferior wall, infralateral wall. All of this is hibernating myocardium. So what would you do in this patient? Low ejection fraction, heart failure, substantial viability, revascularize the patient. So this patient got revascularized, and here's the echocardiogram following revascularization. Nice improvement in ejection fraction. He was 86 years old, so he had multi-vessel PCI, not CABG. So again, FTG PET remains the gold standard test for assessment of myocardial viability, and it makes a difference in managing really complex patients. What about infective endocarditis? This is a growing indication. Here's a patient with infective endocarditis. You can look at the CT without contrast. You can't find any problem. If you do CT with contrast, you can clearly see that area of abscess right there. But you still don't know whether that's infected or not. You go ahead and look at the FDG image. You can see intense FDG uptake there. When you fuse the CT with the FDG, you see that the FDG uptake exactly co-localizes to the CT finding, confirming that this patient has an abscess. Of course, patient went on to have surgery. The other advanced heart failure application is PET for transplant vasculopathy. Here's an example of an extreme situation. 66-year-old with prior cardiac transplant 19 years ago now comes with mild weight gain and dyspnea on exertion. Here you can see overt perfusion defects, significant ischemia, and here's the ejection fraction, 51% at rest and much lower on the stress. I'm not sure why the gated file is not playing. It's playing, but you're not seeing it. Okay. Here's the angiogram on this patient. No obstructive coronary disease, that's evident. But if you look at the flow reserve, again, consistent with what you're seeing visually, significant reduction in flow values. This patient has transplant vasculopathy and was managed. So to summarize, why PET? I think it's primarily superior diagnostic accuracy for ischemic heart disease, both in terms of detection of microvascular disease and better detection of epicardial disease. Of course, an added benefit is lower radiation dose. So if you can get better quality images with lower radiation dose, why not? It's really effective to exclude high-risk ischemia, which remains a problem with SPECT currently. And PET remains indispensable for management of patients with advanced heart failure or with complex heart disease. So for all these reasons, I think whether or not we have access to PET at this stage, I think we should all be considering to get into PET. And I know Dr. Soman is going to talk about a lot of advantages of SPECT, and I fully agree with him. We do a lot of SPECT in our lab. In fact, the primary practice in our lab is SPECT. But in the right context, I think PET makes a lot of sense as well. So thank you very much for your attention.
The last speaker is Professor Prem Soman.
So Sharmila had the best strategy. She agreed with me even before she heard what I had to say. So I have no chance here. Thank you, Nathan, again for the invitation. Good afternoon, everybody. Now, I have a few disclosures. Actually, they're confessions. Some years ago, when we decided to do PET, guess where I went to learn PET? To Sharmila's lab. And I have a speed dial number on my phone, advice on PET, and it's Sharmila's number. So with those disclosures, to paraphrase a very famous piece of literature, we're all playing a role here today, but I'm going to take that role very seriously. So let's frame this question, right? The question is PET as good, is SPECT as good as PET? And of course, the versatility of PET that Sharmila described, that's not in question, okay? We know that PET can do many things that SPECT cannot, and SPECT can do a few things, like dual isotope imaging that PET cannot. So that's not a comparison. So what about myocardial perfusion imaging? And let's frame the question. The question is not, does PET have some advantages over SPECT, or not even does PET have many advantages over SPECT? Perhaps it does. But the question is, if we consistently use PET instead of SPECT, will patient care and perhaps outcomes be consistently enhanced? Is the complexity and the cost of PET justified by a consistent improvement in patient outcome? So what's so good about PET? We think it does robust attenuation correction, and so we expect an increased specificity. Look at the trials. There are only very few trials that have directly compared SPECT to PET. And look at the Flupiridas study, the best tracer you can think of. Co-primary endpoint, superior sensitivity, that endpoint was met. Non-inferiority of specificity was not met. SPECT had a greater specificity than PET. And you know what? It was uncorrected SPECT. It was not attenuation-corrected SPECT. Really interesting. And this is a consistent finding across studies. You saw the Pacific study. Yes, PET had a slightly increased sensitivity, but look at the specificity. Really intriguing. Non-attenuation-corrected SPECT, consistently showing a superior specificity to PET, and one of the most touted advantages of PET is robust attenuation correction. We don't know why. The ability to use high extraction tracers, fantastic theoretical advantage, but Sharmila and 2 other people in the world have access to ammonia, right? The rest of us have to deal with rubidium. And it doesn't even have an extraction fraction that is as high as thallium. So in reality, not really an advantage. Better image quality. Nathan, which is the PET image? If I told you the first image is the PET image, you will say, no, but that is rubidium PET. And you know, because of the positron distance, resolution is not the great advantage of rubidium. And in fact, that is a CZT crystal image from my lab, which has a better resolution than PET. And you know what? This is a beautiful CZT crystal SPECT study in a patient who's 460 pounds. Non-attenuation corrected study. Lower radiation, we can go as low as 2 millisieverts with low dose stress only imaging. Better patient comfort. 3 minutes for a 15 millisievert study. In fact, this guy is begging to be on the camera longer so that he can finish his beer. No, we don't do that. We don't do that in my lab. What about quantification? Here is a study from my lab. Really interesting one. We do SPECT quantification now. And when I started reading this study, I saw this inferior perfusion abnormality at rest. That was much improved on stress, and I said, this is an attenuation artifact. But the wall motion was really abnormal. And it turns out this is a patient who had a myomectomy for hypertrophic cardiomyopathy. And look at the numbers, right? So in the RCA territory, resting perfusion is really low. The stress is slightly better, as you would expect in hypertrophic cardiomyopathy with a myomectomy. And the flow reserve is normal. This is why you have to look both at peak flow and flow reserve. So SPECT flow quantification, not ready for real time, but we definitely can do it, as Barry will tell you, and this is our setup. Now, yes, the diagnostic accuracy of PET is a little better, but is that the full picture? It's like this rather docile-looking morning scene, except the real deal is like this. Right? So there are a whole lot of things about PET that you need to be considered. It's a really complex, getting a camera, deciding what to do, who's going to read the lungs, are the radiology guys going to help you? There's just so many other things to think about. Now, how are we doing with PET? Does patient outcome suffer because we don't use PET? With more than 30 years of good evidence of the excellent prognostic value of PET. And what is really happening here? See, I showed this data this morning. In fact, today in most labs in the United States, only 10% of studies are positive anyways. We are already testing low-risk patients. So what do we want to be? Do we want to be detecting more mild disease? Or do we want to be detecting, we're better at influencing outcome? And I saw that very mild inferior defect that Sharmila showed, and Joao was squinting real hard to see that. I thought your glasses were going to fall off, right? So, how much sensitivity do we really want? And here is the Pacific trial, again showing a slightly better sensitivity, but a much lower specificity. And remember that this was based on flow alone. It's O15 water. Lower radiation from PET, yes, but how many more cats? Because we are detecting mild disease with less specificity. And is patient outcome any better? There has never been a direct head-to-head comparison of PET and SPECT with muffled myocardial perfusion imaging. There's one very unique study looking at the impact of test choice, PET or SPECT, on outcome after viability. The study is very old. It's from Hans Siebelink, and the physicians were blinded as to whether the data were coming from PET or SPECT. Decisions for revascularization were made based on this unblinded data, and there was absolutely no difference in outcome. So this is the sort of data we want where the patient outcome is improved. So I couldn't figure out why the Brigham guys are really excited about PET. So I snooped around, and I went to Sharmila's website. And this is the cardiovascular nuclear medicine website. And if you go to procedures and tests, it's a really detailed website. They talk about varicose vein treatment, vascular imaging, dialysis access, and they differentiate cardiopulmonary stress test and exercise tolerance stress. But when it comes to cardiovascular nuclear medicine, no difference between specimens. I rest my case.
Thank you very much, Prem. I think the Queensbury rules have been officially broken now, and